what we do, when we do it, and how in 25 minutes of nets. So I'll do my best. First of all, I have no disclosures. I work solely in the public system and have made my way here of my own accord, and the opinions are my own. In the background, I think it's important to understand that I'm a medical oncologist. Those of you who have not met one of our ilk, we are the accountants of the medical world. We are particular, we are dull, we like numbers and detail, we are not a lot of fun at parties. What is the nature of the condition we're treating? Well, this is a graph looking at a change over a decade from a recent publication. On the top line showing us the incidence of neuroendocrine tumours in the yellow and all neoplasms in the blue. And you can see the steady, consistent rise in neuroendocrine tumours over time, showing a relative stable picture when we look at cancers as a whole over those decades. This is an emerging condition, you could argue. What do we know about NETs? What's important? Well, how we treat them is governed by a range of factors, some of which have helpfully been pointed out by earlier speakers. One of the key things here relates to the location of the tumour, and the graph on the left shows you the rising incidence of various locations of neuroendocrine tumours, and on the right side, importantly distinguishing the increase or changes over time in a couple of factors. I don't want you to pay too much attention to that, except that we've divvied up something into localised, regional, distal, and then we have grades. So grade, location, and distribution are all factors in how we manage this disease. Why is location or primary site important? Well, they behave differently. When we look at this from a recent publication, it's a relatively simple pie chart. In the big picture there is the distribution of the primary site of cancer. The circle in the middle shows you the percentage of patients with that primary site who present with metastatic disease. So where your cancer originates interrelates with your likelihood of having metastatic disease at outset. The interplay there is complex, and unfortunately that will be a word you'll hear me say a lot during the course of this talk. The other thing we need to weigh up, as I say, is grade and distribution when we think about how we manage things. On the top we have median overall survivals. I'm afraid I missed the audience attendance session. I'm aware some of you are patients, and I'm aware others are members of the healthcare profession. I apologise for my slides coming up. I'm a medical oncologist. I deal in numbers. There will be some discussion on prognosis and survival curves. Please try to remember we're talking in a generalised setting, and don't put yourself on the graph too quickly. So, the key thing in trying to talk about how we manage neuroendocrine tumours, what we choose to do and when we do it, relates to this concept, which is it's really, really tricky. And that's because, unlike I think in my practice as a medical oncologist, any other tumour I treat, these tumours are very much individualised. There are so many factors that come into play that I cannot even start to talk about various aspects of the treatment in this talk, because people may leave here going, well, he didn't mention somatostatinomas, and that's me. I just can't squeeze it all in. So we need to think primarily in some broad sweeping principles. One of the first things we want to think about is the extent of the disease that we're dealing with. Is it singular? Is it a couple of tiny lesions? What is the distribution of that disease? Is it throughout the body, or is it only in a couple of organs? We also need to determine how quickly we need to move. Is the tumour behaving with a fast growth pattern or a slow growth pattern? We need to work out where the primary site is, and I apologise for our embryological nature in medicine, but we often divvy these things up into foregut, midgut, and hindgut, and then pancreas. We've touched on the role of grade from the pathologist, who I do occasionally meet. And importantly for me, that's looking at those differences between grade, as well as the differentiation, which is a fancy medical way of saying how the tumour looks down a microscope. Does it look like a cell next to it? Is it looking a lot like a normal bit of pancreas, or does it look nothing at all like it? It's shed its associations. Very important for me, because I deal with patients, is the hormonal functional status with regards to the impact it has on a patient's life and quality of life. And then, as mentioned earlier by my colleagues, the uptake or the role of whether or not the tumour expresses somatostatin receptors. So, how to manage neuroendocrine tumours in 20 minutes. The first thing we need to think about, and I'm not going to touch too much on, is where the disease is. I think for the purposes of this talk, if it is very small and it is in one organ, it should be removed with curative intent from a surgeon. My early days in training taught me that I am not a surgeon, and there are several disfigured people around Ashburton who dealt with my early attempts at suturing. I love and respect my surgical colleagues. They have a talk coming up. I will leave the discussion of management of primary sites and localized disease largely to themselves. I will focus my talk more on where I live in the world of distributed disease. What options do we have when the cancer is only in the liver? We have a range of options. There are things including the use of squirting chemotherapy directly into the liver artery, which we know supplies some of the blood flow to the cancer predominantly, rather than the healthy liver. We've worked out, and we still debate, and we're not really sure, whether or not chemotherapy squirted into the liver is any different to squirting anything else into the liver, such as something we call bland embolization. And the role there may be less the chemo working on the cancer and more blocking the blood flow. We can put tiny radio-emitting beads onto things and squirt them into the liver. We can put drug onto tiny beads and squirt them into the liver. We can use a wire from inside or outside a person into the liver and turn on a microwave inside the liver and, inverted commas, cook it locally, and we call that radio frequency ablation. Apologies to the radiologists for my somewhat crude description. So with liver disease alone for a neuroendocrine patient, we have a very complex shift when we look at how we manage them. If we look at all comers, some will be candidates for resection, some will not. Even though they may not be able to be resected, they may still benefit from a range of liver-focused interventions, such as ablation, transarterial embolization, that's the TAE. If we put chemo in it, we make it TACE. If we use radioactive beads, it's called SIRT, or, as we'll come to later, a radioactive compound that goes everywhere, or the little purple person who's not very well featured, which is medical, which is where I work. So we need to consider the distribution of the disease regardless of where it's come from, its grade, and how it's behaving. What other things do we take into account? Well, I quite like this slide, and you'll see it frequently, because these are the things I need to think about when I see a patient. I've got to factor in the primary side of the cancer that tells me how it's likely to behave, what it's likely to secrete, and where it's likely to go. The grade of the cancer tucked down the bottom, with the somewhat challenging phrase underneath it, which I'm less a fan of, but does come up, aggressiveness. That is a very subjective phrase, and I try to avoid it with patients. It can be quite a difference if we use the word aggressive. And then we've got the disease burden there listed on the side. But the most important one early on for me in seeing a patient is the one that I've struggled to put in there, which is functional status, so I've just slapped it in the middle. And then I started to run out of all the other things that I need to think about. As I mentioned, I work in the public system in New Zealand, so unfortunately a component of this involves health insurance, financial ability to access treatments, and that all plays a part in what treatment I choose. So with regard to function, what do we do? Apologies again, as I say, we are somewhat boring beasts, and so this will feature various publications and journal articles. This was published as the original study back in the mid-2000s. It's the PROMID study, and was the first study that looked at comparing a placebo versus the octreotide treatment that we often use now in the controlling the growth of cancer with neuroendocrine tumours. And when we looked at that study, this is a consort diagram, and it tells us that they split the people into placebo or people getting octreotide, and it tells you what happened to them. It's a way we look at reading our papers. I don't expect you to pay too much attention to it. The key thing for me is that at this area here, I'll just check that that's laser, you can see N is number of patients. The number of patients who were on the study who got the drug were 42. There are more probably in this room than this international randomized phase 3 trial that changed practice around the world. So the first thing I want to do is to say we struggle to do these studies well, and the evidence and the data we get is a far cry from that you see in other cancer types. Breast cancer studies in this situation would probably have several thousand patients in each of those arms. The colorectal cancer patients, I would expect to have several hundreds of patients. Lung cancer, hundreds of patients. Neuroendocrine, 42. 42 in the other arm. What did we see? Well, on the top, whenever we do a study, we have to pick what we're trying to do. And unfortunately, we don't quite know what we're trying to do with neuroendocrine tumours. Are we trying to shrink them? Are we trying to make someone feel better? Are we trying to slow the cancer down? Or are we trying to make them live longer? We would like to do all those things, but how long you keep an eye on someone and what you focus primarily on helps guide your outcome. This study used progression-free survival, and on the top, that's the graph, which is looking at the time it took for a cancer to grow on CT imaging. The graph at the bottom is overall survival. You will see that you cannot put a piece of paper between the two lines. So octreotide did not demonstrate a survival benefit in this situation. It did appear to slow the cancer down, but most notably, it caused a significant reduction in functional symptoms from secretion of hormones, and we were able to control that in 60 to 70% of patients. There is another drug called lanreotide, and it was published a little later in a different journal. It works very similar. They target the somatostatin receptors 2, and then a little bit of 1 and a little bit of 3, but not 5. And there's another agent called pasireolide. So this is their graph. They got a little bit more patients in because they did their study later. We have 100 patients in the arm. This is progression-free survival on the top and placebo on the bottom. And when we look at whether or not or who benefited from this treatment, it looks like all patients tended to benefit regardless of where their tumour was, and importantly, what grade it was. There was also a split looking at hepatic tumour volume. From the PROMID study, there was a subset analysis assessment that patients with low volume liver disease probably did better. So an inkling that maybe we should think about starting these drugs while the disease is relatively small. Overall survival, however, in the Clarinet trial did not show a difference. So these drugs have not been shown to make patients live longer. The challenge for me as a medical oncologist is I try and be honest, so I have to tell my patients that. There is no evidence of a survival benefit. That makes it very challenging to get these drugs funded by the New Zealand government. The reason there is no survival benefit is because after the study, the placebo people all went largely onto the drug. So it's less a study of does the drug work or not, but when you give the drug, and it seems that it doesn't matter too much when you give the drug with regards to making you live longer, so long as you get the drug. It does make a difference for making your cancer grow. The sooner you get it, it's more effective at slowing or controlling the growth of cancer, progression-free survival. So, I've sort of touched on functional status and those of the drugs. In reality, I'm now going off-piste as a medical oncologist in the public sector. I have already discussed with you my treatment, the one drug I have that is proven to do something useful that the government will fund, and that's octreotide. I have shown you its equivalent drug, and by and large, everything beyond here is me with my nose pressed against a glass window, wishing I could use some of these other things to help people. One of the treatments that we discovered was a targeted drug called everolimus, or in the early days, RAD001. And those of you who, I hope, are going to encourage your children or take a career shift into medical oncology and want to impress at parties, this sequence of studies is referred to as the RADIANT studies, the RADIANT group, and that's because RAD001 was the name for everolimus before they did it. So you can tuck RAD and RADIANT in your mind and start talking about these with conviction. This looked at using these targeted drugs in pancreas cancer tumours that were neuroendocrine, and we chose that starting point because we know pancreas neuroendocrine tumours tend to respond a little bit better to systemic treatments. They also tend to do a little bit less well with regards to survival. The graphs on the top are progression-free survival, and we saw a statistically significant difference in progression-free survival between the use of this drug or placebo, and on the bottom we saw no difference in overall survival. That is the threshold whereby the New Zealand government would like to fund drugs, so this drug is unlikely to cross the threshold on a survival curve alone. When we looked at how it worked to shrink the cancer, these graphs are designed for you to look from the back of the room. On the left, as you look at it, is the everolimus graph, and we've got the change in a lump on a CT scan. If it's blue, it's decreasing. In oncology, we like to measure things particularly, and so we refer to this as response rate. To have a response rate, you need a very measurable shrink in the cancer over a threshold, and that, unfortunately, is quite hard to do. The majority of patients on these trials, although we're seeing this long blue line, don't tip over our threshold for actually counting as shrinking. Because when you measure a lump, it changes day to day because you're not very good at measuring. So we have to pick a threshold where we're confident it's got bigger or smaller. So as a result, when we'd published response rates with these drugs, they sit in the range of 5 to 9% of people getting a shrinkage of their cancer. The reason for this is to show that there's a general trend that they do something. It's just very hard to say that they've crossed the bar for us. We then said, well, if it works in pancreas cancer, can we give it with octreotide, our functional drug, in patients who have carcinoid syndrome? And that became the RADIANT 2 trial. Again, we divvied it up into 200 people in each arm because it's getting later in time and we're getting better at finding neuroendocrine patients and putting them into clinical trials. Again, we saw a progression-free survival advantage. It looked like it benefited everyone across the subgroups. And when we looked at response rates, we looked like, again, although it didn't across our margin very far, there was a general trend that more people were blue on the drug. Again, suggestive that we're on to something, it's doing something, but is it enough? We then finished it with Radiant 4, where we gave it to non-functioning tumours, and again saw similar graphs. So we know that this drug works compared to a placebo-controlled arm. The top shelf level of evidence for medicine where I sit, a randomised, placebo-controlled, blinded trial, and it worked in pancreas and secretory nets as well as non-functioning nets. Everyone seemed to benefit. At the same time, in 2011, another drug was published in a similar setting, just looking at pancreas cancers. It's called sunitinib and is funded in New Zealand at the moment for the use of renal cell carcinoma. There's a tablet taken once a day, like everolimus. And again, we saw a surprisingly similar progression-free survival advantage, around about 4 months on placebo, going to about 11 months on the sunitinib, almost identical numbers to the Radiant study, and again, a shrinkage of the cancer, and again, a trend suggesting that it worked across the board in most people, regardless of Ki-67 or number of disease sites. And this one pleasingly worked in both men and women, whereas everolimus seemed to have a trend to be more effective in women, for reasons we don't understand. As a medical oncologist, my training's partly in giving chemotherapy. So, can I give chemotherapy to these cancers? Well, this is a very old paper looking at a very old combination of drugs that was our standard of care called streptozotocin, and comparing it, what was the standard at the time, streptozotocin 5-fluorouracil versus streptozotocin with doxorubicin. It did show a significant chance of shrinking the cancer or controlling the disease. The challenge for us is we didn't measure things as well in the late 80s, early 90s as we do now, and most of that response rate listed there wouldn't count on a modern study as shrinking the cancer. And to be honest, it's a pretty cruel thing to give someone doxorubicin and streptozotocin. The side effects include nausea, vomiting, hair loss, possible cardiac damage, myelosuppression, and a range of fatigue, nausea, skin rash, allergic reaction, risk of secondary malignancy. I could keep going on. So we thought, can we do things better? Yes. And I've tried, as per the request, to reference my slides where possible. This was released at the American meeting for cancer specialists in 2018. The reason I have these slides up for you and not a paper is that it's yet to be published. And so this group looked at randomizing a chemotherapy drug called temozolomide versus capecitabine and temozolomide. There was good rationale to thinking it would work, and because we're using a chemotherapy drug, we chose pancreatic neuroendocrine tumours to start. They randomized people, 72 in each arm, to one drug versus 2-drug chemotherapy, and they chose to give no more than 13 cycles of treatment. Because we're nerds and we like to measure apples with apples, I will point out this was a Braeburn apple versus a Granny Smith. They're both apples. They're just not quite the same in that the control randomization happened to put a little bit more of the low-grade tumours into the combination treatment and a little bit more of the higher-grade ones into the one-drug one, suggesting there's a chance that the combination may have a slightly better group to work on, and so may be an outcome may be not due to the drug, but more due to the randomization process. Patients were actually able to complete a surprising number of cycles of chemotherapy, and we saw an improvement in progression-free survival. The overall survival looks interesting, but I will caution you to say that those are not statistically significant. Although the graphs separate, that doesn't mean it's enough for us to say that there is a clear difference. Time will hopefully answer that. We did see that the chemotherapy was effective in shrinking the cancer or holding it where it was. And so with regards to either removing all the cancer, something we call a complete response, or shrinking it a bit, something we call partial response, we saw that in about 30% of patients. It didn't seem to matter if you got one drug or two drugs. So I keep an eye on the clock and creep myself closer. The thing that all my patients ask me about now, used to ask me about a couple of months ago, everyone asked me about immunotherapy drugs for their cancer, no matter what they were. Now they ask me why I'm doing so poorly versus other countries, and whether or not we should have a cancer control agency. This is a poster publication. Again, apologies that I don't have pretty slides in detail. This is because this is what we have internationally. This was released at the American Society of Clinical Oncology, the big cancer meeting in America that happens once a year. And this was in the GI group. It was released in January 2019. It's looking at an immunotherapy drug called pembrolizumab. It's looking at giving it to patients with neuroendocrine tumours. So these drugs that have carried a lot of hype with good reason for some patients in oncology are being applied broadly across a range of tumour types. And from the study, I've pulled up the key graphs for you there to show that the response rate, or the chance of shrinking the cancer with these drugs, was actually quite poor. A little disappointing, but everything I've just told you was a little disappointing. We tend to sit with everolimus and octreotide and response rates between 2 and 5%. So although it's not a dramatic shrinking of the cancer, we need to remember for NET tumours, it's not always about shrinking. Sometimes it's about holding and controlling and slowing. So we're still learning in this space. The bottom graph there, I'm hoping that you're starting to get familiar with what we refer to as a waterfall plot. And that shows you your chance of shrinking cancer. Classically, we put the shrinking down the bottom, and we're able to see that this is our threshold for response. So again, not many people having this response. Each one of these bars is a patient. This is a marker that we know from some cancers may help guide who may benefit from the immunotherapy. And they chose, we would expect, this PD-L1 positive subgroup to probably be down here. What we're seeing is it's not. That could be surprising and disappointing. I will confess I'm a little cynical about the utility of that test across the board in all cancer types, and I think it's pretty rubbish. It certainly is in neuroendocrine tumours. So, is there anything else we can do? Well, luckily, thanks to wise heads, and I think you get to meet Dr. Ben Lawrence later, a cleverer and prettier version of myself from the North Island. We're very busy looking at what makes up these tumours, what the genetic changes are. I don't want you to pay any attention to this. It's a recent publication looking at whole genome landscape genetic changes in pancreas cancer, the pancreas neuroendocrine tumours. These are the things that fill me with joy as I go to bed and read at night. I don't expect you to pay detail, but fundamentally we're starting to spot some trends, some groups, some changes in the cancers that may help us pull apart an already diverse group of cancers into yet more diverse groups of cancer, which will mean that it becomes even more individualized, that your grade 1 insulinoma that's metastasized somewhere and is secreting a little bit happens to have a particular mutation, which means you're different from the one other person like you in the southern hemisphere. It does make it very challenging to treat. Lastly, because I meant to touch on treatments and how we pick them and why, I'm trying not to steal thunder, but I will say, obviously, an important treatment to talk about in this space is the use of peptide-related receptor therapy, or PRRT. This is the clinical trial that showed benefit from it. We call it NETA-1. The key things for me, because I'm a particular beast, is that everybody was on octreotide in this study, and you weren't able to get onto the study unless your cancer was shown to grow or be increasing on octreotide. So that's the subgroup where this data sits at the moment. It's the best data we have. And what we saw was that there was a range of Crenning grades, which luckily you all know all about now. There were some markers there, and we distributed things pretty evenly between the groups. And we saw this very different graph from the one that I showed you before, showing a split between the PRT or lutetium dotatate scan on the top versus the control arm on the bottom. The control arm is octreotide 60 milligrams. It was felt that you couldn't do nothing in the context of a cancer that was growing on octreotide, so they made the decision to double the octreotide. The likelihood of that working to do anything is extraordinarily low. We know that the receptors on the tumours tend to get pretty saturated around 60 milligrams dose, so going above 60 doesn't tend to do any good at all except create more bruises on an already sore patient. The response rate, 18%, is pretty unimpressive as a medical oncologist for shrinking cancer, but as I've mentioned, for neuroendocrine tumours, it's not a good marker of what we're trying to do. We're not really going to see a dramatic shrink. So, what can we propose? If you have a mid-gut neuroendocrine tumour, you should go on a somatostatin analogue. That's our fancy way of saying octreotide or lanreotide. And then you could consider PERT, local liver therapy, or everolimus. If you have a non-mid-gut GI net, so large bowel or stomach, lung, importantly, which I haven't spoken about. Again, you can see a similar profile of somatostatin analogue. Those of you paying close attention know that's Radiant and Radiant 4 are pinning the everolimus data, the PRT data, chemotherapy sneaking in there. And if you have a pancreatic neuroendocrine tumour, again, chemotherapy, everolimus, sunitinib. I can give capecitabine. I have recently been allowed to give temozolomide by the government for this disease. Almost everything up there is largely out of my hands, and hopefully we'll hear an update later that we may have another tool in our box. So at that point, I'm going to pause